My name is Todd Bergman. I'm the Director of Therapeutic Services at River Edge Hospital in Forest Park. Here our team at River Edge Hospital is so grateful to participate in the summit as we continue our zero suicide mission here, learning from such incredibly gifted presenters. I have the great opportunity and honor to introduce Dr. Jennifer Hoffman, Assistant Professor of Pediatrics at Ann and Robert H. Lurie Children's Hospital of Chicago. Dr. Hoffman will be presenting on youth suicide disparities in high poverty and rural areas. Dr. Hoffman's research interests include pediatric mental health emergencies, access to healthcare, poverty, and social determinants of health. Throughout this presentation, we encourage you to submit your questions in the question answers, and we will respond to as many questions as we can after the presentation. So at this moment, I'd like to introduce and welcome Dr. Hoffman.
Thank you, Dr. Bergman. I'm excited to share with you today my research on youth suicide disparities in high poverty and rural areas. I have no disclosures to share with you today. And in terms of my objectives, today my goals are first to help you understand more about the epidemiology of youth suicide in high poverty and rural areas. Second, I'll be describing some of the upstream factors that may contribute to youth suicide in high poverty and rural areas, because understanding these upstream factors is very important as we think ahead to designing interventions and prevention strategies to try to narrow the disparities that exist. And I'll be doing all of this through a lens of exploring how large existing data sets, such as those that are nationally represented, can be used to study youth suicide disparities. In particular, I'll be diving deeply into two of my own original research studies, and I'll walk you through my analysis and interpretation of the data. And I also recognize that there is a wide range of backgrounds among the audience members. So for researchers in the group, I will be presenting some statistical terms, but I also will try to explain the big picture concepts along the way for this to be understandable for the whole group. And really, I hope that you come away from my talk with a greater appreciation of the power and potential of using big data sets to study youth suicide, as well as understanding some of the limitations of using this approach. Because we do always have to pair our knowledge generated by big data with individual stories and lived experiences, such as those shared today earlier by Kylie and Gray, in order to really know how to interpret the data and what questions to ask. So we know that children are directly influenced by their environment as they grow up. And their environment includes both individual household factors as well as the neighborhood or the community environment where a child grows up. And we know that a child's environment directly influences their health behaviors and ultimately their health outcomes, with the health outcome of interest today being youth suicide. And the relationship between a child's environment and health outcomes is fairly complex. So it's important to have a framework in mind as you try to organize different concepts to study these relationships. So I've been relying on a particular conceptual model to help study the environmental influences on youth suicide. This is the behavioral ecological model of healthcare access and navigation. And it shows how a person can interact with their environment to culminate in health behaviors that then lead to health outcomes. So in particular, an individual's characteristics interact with their social environment, healthcare environment, built environment, and neighborhood demographics to interact together to determine personal health practices and realized access to care, which, for example, is visiting the doctor or visiting the emergency department. And these influence ultimately health outcomes such as youth suicide. There's also a contribution of individual provider factors as well. So in looking at these relationships, it's really helpful to try to isolate one arm or one branch of these relationships and study individual aspects of the environment and how they relate to health outcomes while adjusting for or controlling for the other variables in order to develop a greater understanding overall. So today I'll be sharing with you how two different aspects of the social environment, community poverty and community rural urban status, have an influence on youth suicide. So in my first study that I'll share with you, I'll be describing the association between community poverty and youth suicide. And in the second study that I'll share with you today, I'll be describing the association between community rurality and a more proximate outcome, which is emergency visits for youth suicide and self-harm. So I'll jump in first to the first study, which explores the association between youth suicide and poverty. I chose to study poverty because it's previously been associated with a number of other negative child health outcomes, including rates of infant mortality, child abuse, and injury. But the relationship between youth suicide and poverty is less well understood. And we know that children experience poverty at both the individual household level as well as at the neighborhood level, and both may have distinct impacts on health outcomes. So children living in high poverty households may experience a more stressful home environment, including a higher risk of witnessing violence in the home, having a parent in jail, or experiencing physical abuse. While children living in poor neighborhoods may not have adequate infrastructure to help support adequate child mental health and wellness, such as safe parks, high quality schools, or availability of mental health services. So with these factors in mind, my work built on several prior studies in this area. There was one study in Canada that showed an association between neighborhood poverty and a correlation with youth suicidal ideation and attempts, but this study did not examine suicide deaths. And another study in Sweden showed that household public assistance was associated with double the adolescent suicide risk. In the United States, there have been some prior studies showing that suicide is concentrated geographically. You may remember earlier in the talks today, Dr. Davis showed some heat maps of neighborhoods in Chicago. And studies at the county level in the United States have been mixed. So there was one study that showed a correlation with suicides and counties of lower socioeconomic status in Ohio, where another study found opposite, that suicides were correlated with areas of higher socioeconomic status in Florida. However, neither of these studies were nationally representative, and they focused on all suicides rather than particularly on youth suicides. So that brought me to my study objective, which was to determine if there is an association between pediatric suicide rates and county level poverty in the United States. For my methods, I conducted a retrospective cross-sectional analysis, which means a look back over time, of suicides by US children 5 to 19 years old from 2007 to 2016. And I merged two large data sets for this work. The first is the CDC's compressed mortality file, which consists of death certificate data for all deaths in the United States. And they're grouped by county, year of death, as well as cause of death, which includes the intent. In my case, I was interested in suicide deaths, as well as the mechanism of death, such as firearms or poisoning. And I merged this data set with US Census data that described county population demographics and county poverty statistics. For my statistical analysis, I calculated suicide rates across the demographic categories, and I set up 5 county poverty concentration categories. These were based on the percentage of the population living below the federal poverty level, which is approximately an income of less than $21,000 for a family of 4 during the study time period. You can see here the 5 groups of county poverty concentration, where the lowest poverty counties had 0 to 4.9% of the population living below the federal poverty level, and the highest poverty counties had more than 20% of the population living below the federal poverty level. Then I did some statistical modeling, and the overall goal of this model is really to isolate the association between county poverty concentration as the exposure and the outcome of youth suicide rates. And to do that, I controlled for or adjusted for several other covariates that may influence the relationship, including the year of the suicide, child demographics such as age, sex, race, and ethnicity, county demographic composition, and county rural urban classification. And then I stratified by method of death, including suffocation, firearms, and poisoning. So this table shows the demographics of suicides by US children during the study period from 2007 to 2016. Overall, there were just above 20,000 suicide deaths, yielding an annual suicide rate per 100,000 youth of 3.35. Then I calculated something called the incidence rate ratio, which is a marker of the relative risk of suicide in one group compared to another group. And 1 in this case means no difference. So among older youth, 15 to 19 years old, they had a much higher suicide rate risk compared to elementary school age youth, which is expected. And then males had a 3-fold higher suicide risk than females. In addition, we found that Black, Hispanic, and children of other races and ethnicities are at lower risk for suicide than white non-Hispanic youth in the United States. They have about 2/3 the suicide rate. And this is particularly important as we move on to consider communities where there are high levels of poverty, because on average, those communities have higher percentages of minority youth. So we would expect potentially, based on the demographic composition of these areas, that there might be lower suicide rates. Next, I looked at the unadjusted or the raw annual suicide rates by county poverty concentration. So in this table, each row represents a different group of counties based on the percentage of the population living below the poverty level. The first column shows the total number of children living in each of these groups of counties, and in parentheses, the percentage of youth living in each of these areas. Next, I found the total number of suicides in each of these county groupings and the percentage of suicides that occurred in each of the county groupings. And then I calculated a rate to determine the annual suicide rate per 100,000 youth in each of the county poverty categories. And you can see it here that the rates are not too different from one another. But importantly, you can see that the percentage of Black and Hispanic youth increases as the county poverty concentration increases. So based on the demographic composition, we should be seeing lower suicide rates in these high poverty areas. It's only when controlling for or adjusting for the demographic differences does a relationship between poverty and suicide become apparent. So I'll spend some time on this figure, which illustrates my main study results, the relative risk of suicide by county poverty concentration and by mechanism. So to orient you to this figure, the y-axis shows the suicide adjusted incidence rate ratio, which shows the relative risk of suicide in a given county group compared to counties with the lowest poverty concentration, 0 to 4.9%. And here, the red line of 1 would indicate no difference. So in the first blue panel, this is suicides among all mechanisms. And you can see that the relative risk of suicide increases in a stepwise manner as the county poverty concentration increases, such that children living in the highest poverty concentration category with greater than 20% above the federal poverty line had a 1.37 times higher risk of suicide compared to children living in the lowest poverty concentration. Then I stratified by the method of suicide. And here you can see that when you look at suffocation deaths, such as hangings and poisonings, there was no difference across the county poverty concentration categories that was statistically significant because the error bar crosses 1. But when you look at firearm suicides, the relationship was even more pronounced, such that children living in the highest poverty areas had almost double the risk of suicide, 1.87 times the risk of suicide compared to children living in the wealthiest areas. So I dug into the data a little bit further after this. And next I explored something called an interaction effect. So an interaction effect tells you what other variables could be influencing the association between poverty and suicide. And I found a stronger magnitude of association between poverty and suicide among younger children, showing potentially that younger children who die by suicide are more influenced by environmental factors, such as community poverty. And then I looked at race and ethnicity, and I found no difference between Black and white youth in the relationship between poverty and suicide. However, I did find that the magnitude of association between poverty and suicide was more than 2-fold as strong among children of other races and ethnicities. Now, this is a heterogeneous group, which includes children who are Native American, Asian American, and multiracial. And I was not able to stratify further and break this up due to the small numbers of suicides in this group, but this is an area that certainly deserves further study. Additionally, I found that suicide rates increased by year, which has been previously demonstrated in 2016 compared to 2017. And I broke down the suicides by rural urban areas and by mechanism. So suicides were more common in rural areas, 66% more likely. And then in particular, firearm suicides occurred more than twice as commonly in rural areas compared to urban areas. Some limitations of this study included that household poverty status was not available for analysis in any of the data sets used. So I was unable to distinguish the relative contribution of household versus neighborhood level poverty. And also there's potential for misclassification on death certificates, both in terms of the demographics of the children who died, as well as potentially in their cause of death as being suicide. So the conclusions of this study are that higher county poverty concentration is associated with increased pediatric suicide rates in the United States. And this relationship is particularly pronounced for firearm suicides. But how poverty influences suicide risk deserves further study. And we know that targeted suicide prevention efforts must focus on children with the highest identified risk. So this study newly identifies county poverty concentration as an additional risk factor that's independently associated with youth suicide. So now I'm going to switch gears a little bit. If you're interested in learning more about this study, it's published in JAMA Pediatrics. The next study that I'm going to describe to you looks at the relationship between youth suicide and community rurality. So this also builds on prior studies that have shown that there are rural-urban disparities existing in youth suicides. Some studies have shown that suicides are twice as likely among youth living in rural areas of the United States, and this disparity is widening over time. As others in the summit have described, ED visits have been rising over time among youth for suicide and self-harm, and in fact, some studies have shown that ED visits have doubled from 2007 to 2015. And as many of my colleagues in the summit have described, the ED is a ripe area for detection of suicidal thoughts and initiating intervention strategies before it's too late. Some of these could include suicide screening, lethal means restriction counseling, and connection to mental health follow-up. So for these reasons, I really was interested in understanding differences in ED visits for suicide and self-harm in rural versus urban areas, as this may allow us to tailor the different detection and intervention approaches that we're using in rural compared to urban areas. So the objectives of this study were to examine differences in ED visit characteristics and visit rates for youth suicidal ideation and self-harm in rural versus urban areas, and to determine whether mechanisms of self-harm differ in rural versus urban areas for youth ED visits for self-harm. My methods included a retrospective cross-sectional analysis, which means a look back over time, of suicide-related ED visits from 2016. And again, I used two large already existing data sets that I merged together. The first was the Nationwide Emergency Department Sample, or NEDS, which provides a sample of all ED visits in the United States. And I focused in particular on ED visits for suicide and self-harm. I linked this data set with US Census data that includes county population demographics and county rural-urban status. For my statistical analysis, I used sampling weights that help extrapolate these few ED visits that were in this data set to produce national visit estimates. And then I used a statistical technique called chi-square analysis that allows for a comparison of visit characteristics in rural versus urban areas. And again, I built a statistical model with the goal being to isolate the relationship between the exposure of interest, which was the urban-rural location of patient residence, and the outcome of interest, which was the number of ED visits for suicidal ideation or self-harm. And I tried to control for other potential influencing variables, such as the child's age, sex, and US Census region. Importantly, race and ethnicity was not available for analysis in this data set. So I was unable to include that in my study. And after that, I stratified visits for self-harm by the mechanism of self-harm. So in terms of my data, this table shows urban-rural differences in youth ED visits for suicidal ideation and self-harm among youth living in rural compared to urban areas of the United States. There were no differences overall in age or sex of the children who were presenting. However, children from rural areas were more likely to have public insurance. And to me, this really shows the importance of making sure that there's equitable insurance coverage for mental health conditions, regardless of a child's insurance status. Children living in rural areas also were more likely to have a lower median household income for the patient's zip code. And that kind of shows the interaction between my prior study, which was on the socioeconomic variables, and this study, which focused on rural-urban differences. In addition, I found that children who lived in rural areas, about 1 out of every 5 of them actually traveled to a metropolitan hospital to seek care, which may illustrate a lack of definitive mental health care capacity in rural areas compared to urban areas. In contrast, almost all youth living in urban areas were seen at metropolitan hospitals. Also, I found that double the percentage of youth living in rural areas required transfer to a short-term medical hospital to complete their evaluation or management compared to urban youth. And again, this speaks to a potential lack of definitive mental health care capacity in those rural areas requiring transfer. So next, I broke down the ED visit rates by urban-rural location of patient residence. And I looked individually at visits for suicidal ideation and visits for self-harm. So each row here represents a category of urban-rural classification, ranging from large metropolitan to medium and small metropolitan, as well as micropolitan and non-core areas, which are the most rural areas. And you can see that the largest number of ED visits occurred in the large metropolitan areas. And this makes sense because in those populated areas, that's where most of the children are living. However, when you look at the visit rates per 10,000 youth, we actually see the highest visit rate in micropolitan areas, which are sort of suburban or near rural communities. Then I looked at the incident rate ratio, which again allows for comparison of relative ED visit rates between one category and another category, where one indicates no difference. And for visits for suicidal ideation, I found no statistically significant difference across the urban-rural categories. However, among visits for self-harm, there was a statistically higher visit rate in small metropolitan, micropolitan, and non-core areas compared to large metropolitan areas. Next, I did my adjustments. So I adjusted for age, sex, and US Census region to build the final analysis. And this did not change the relationships. So there remained no statistical difference across the rural-urban categories for visits for suicidal ideation. However, there was a statistically higher ED visit rate in small metropolitan, micropolitan, and non-core areas for visits for self-harm. And then finally, I did break down those visits for self-harm by the mechanism of injury. And what you can see is that self-inflicted firearm injuries account for a very small proportion of all ED visits for self-harm. And this may be because firearm injuries are often so lethal that children may die before they even reach the emergency room to receive care. In contrast, poisonings represented the largest percentage of ED visits for self-harm among youth. And then I compared the relative rates in rural versus urban areas. And I found a pretty striking difference among ED visits for self-inflicted firearm injuries in that they were threefold higher in rural areas compared to urban areas. And there was a small but statistically significant increase as well in poisoning-related self-harm visits in rural areas compared to urban areas. However, after adjusting for age, sex, and US Census region, only the relationship between self-inflicted firearm injuries and rural-urban location remained significant, where there still remained a threefold higher rate of ED visits among youth for self-inflicted firearm injuries in rural compared to urban areas. So some limitations of this study include that visits were identified using diagnosis codes, and these may be subject to misclassification. And also, they cannot distinguish between visits for self-harm with suicidal intent, which is also known as suicide attempts, versus self-harm without suicidal intent. Also, as I mentioned earlier, race and ethnicity were not available for analysis in this data set, so it's unclear how adjusting for race or ethnicity might impact the study results. In terms of conclusions and implications, overall, I found that youth who visit the ED for suicidal ideation and self-harm in rural areas are more likely to be publicly insured and to require transfer for definitive care. I also found that more ED visits for self-harm occur among youth living in rural areas, particularly for self-inflicted firearm injuries. And this suggests that targeted prevention efforts in rural areas should focus highly on safe firearm storage. In addition, we should focus on increasing our mental health capacity in rural areas. And one potential emerging solution there includes telepsychiatry, which might help expand that capacity and prevent unnecessary or avoidable transfers from hospital to hospital for these vulnerable youth. So to round out my talk today, I'll go back to the behavioral ecological model that I presented in the beginning, which shows how a youth interacts with their environment to create health behaviors and ultimately health outcomes. And today I described how two social environmental factors, community poverty and community rural urban status, interact with other variables to generate health behaviors such as access to the emergency room, as well as health outcomes such as youth suicide deaths. And in terms of the next steps for my research, I'm interested in exploring a healthcare environment variable to see how it could be playing a role, particularly in the high poverty and rural areas. So for my next study, I'll be exploring how mental health clinician shortages may impact youth suicide rates. Because we know, particularly in rural and high poverty areas, they may be differentially impacted by having a shortage of mental health providers. So I'd like to acknowledge my research mentors for both of the studies. And thank you very much for having the opportunity to share my work with you today. And I hope you'll stick around for closing remarks as well by Dr. Matt Davis. And if there's time, I'll take any questions. Thank you very much.
Dr. Hoffman, that was an incredible amount of work that you had to put into just pull all that data in. So what a great opportunity for a lot of people to advocate for greater services and resources for communities in high poverty areas in rural and urban areas. So thank you. I would love to share some questions. We're down to about a minute before Dr. Davis is going to share his closing remarks. I'm excited to see more of your work in the future.